Hello, everyone, and welcome to Curated Conversations, a podcast brought to you by the Grand Rapids African American Health Institute. My name is Ashley Jones, and I am your host for this conversation. Today, we have two phenomenal guests here to have a very candid conversation with us regarding our opioid crisis. Today, we have Miss Ellen Atkins. She is definitely a familiar advocate here in the community. She is a retired nurse who still serves heavily in that regard as an advocate for those that don't always have a voice for themselves. And she is also one of the health educators at Pilgrim Rest Missionary Baptist Church, who is definitely a partner in the work that we do here at GRAAHI. So, Miss Ellen, hello.
Hello, and hello, everyone out there. I am happy to be a part of this because this is a conversation that needs to be had somewhere, everywhere, all the time. I'm thankful for the opportunity.
And we're so glad to have you. Additionally, our esteemed guest we have as well is Miss Rachel Jantz. Rachel is an epidemiologist with 10 years of experience in the public health practice. She currently serves as a part of the Kent County Health Department, as well as the Kent County Opioid Task Force. We also here at GRAAHI have the privilege of serving alongside them as we look to transform the community and heighten the awareness around opioids, the crisis, the dilemmas, and then hopefully how we can help to eradicate some of the stigma around getting help and assistance when necessary. So welcome, welcome, welcome.
Thank you so much for having me. I'm so happy to be here, and I'm really excited for our conversation today.
So I'm excited about this. So we're going to jump right in. Today's podcast is very near and dear to the hearts of us here at GRAAHI. So we love to kind of jump into some of what we like to say is the science of it all. We know that there's a lot of data, there's a lot of information. There has been a tremendous amount of impact as the opioids have become more of a conversation that some are willing to have. In previous times, maybe not so much. But we love to know how the Kent County Opioid Task Force, more about that, and then how the opioid crisis itself is affecting Kent County.
Yeah, it's a difficult conversation for sure. One that we've been having in the public health space since the late 1990s when the prescription opioid epidemic began. And it recently, I would say 2017, I believe, is when it was addressed as a public health crisis. The Kent County Opioid Task Force started in 2016, and it's a multidisciplinary group of folks from treatment, prevention, law enforcement, child protective services, the community, harm reduction, a bunch of different folks who touch on the opioid epidemic. And we all try to find alignment around the issue and solutions because it is such a heavy topic in our community.
Yeah. So as a part of our community, how are you seeing?
I see Rachel's point of view with the numbers, but I see the people behind the numbers. And it doesn't just affect the person who's addicted. It affects the family. It affects the school. It affects everything that person touches because their life is different because of their addiction. I am happy that there is an organization like this. And I have to say, 2016 was not soon enough. Drug addiction has been a problem in the Black and brown communities forever. The light is being shown on it now because it's affecting others. So even though I'm not happy that it turned out that way, I'm happy that this organization is, because there is an impact, and it is reaching people, it is helping, and it's becoming more than just a number. Statistics are great, but when you peel that layer away and you look at the families that are hurting because of this, it paints a different picture.
And I think by having conversations like this, it helps to eliminate the stigma of people just being a number. So feeling like there is not an opportunity to, really dive into the humanity of it, because just because there is a substance abuse addiction, it's not always by choice. I don't think there's anyone that wakes up one day and decides that I want to have a lifestyle where I am oftentimes debilitated throughout my day. I'm directly impacting my family unintentionally, right? It's not a choice. Sometimes there are circumstances, there are situations, there are traumas that happen where, persons will make a decision in an effort to find a sense of quote unquote peace in the moment, and the peace becomes a problem, and then the problem becomes a disease, and the disease becomes impact, and then we can go on and on from there. So conversations like this, I think, are transformational in so many areas and in places and spaces, because we could have someone that's listening to this that would not have sought out information or would not feel comfortable with even having a conversation.
Exactly. In my experience, talking with people who have substance abuse problems in my community, the thing that I hear most is their helplessness. I can't find a job. The educational system is stacked against me. This makes me feel better, because that's the one control that they have, is what they ingest or what they smoke. A lot of it stems from hopelessness, but some of my patients have also been affected by it because they started out using it to take care of a pain. So every addiction is not because someone just decides they want to be an addict. There's so many reasons, there's so many layers to it.
Right. Yeah, I think that this conversation is so great, because what epidemiology can do is alert us that there's an issue with data, right? So we know that now in Kent County, there's around 85 people a year who die of an opioid-involved overdose. That is at least 3 times as high as in the early 2010s. And we know in our community since 2020, the disparities between our Black and white residents has increased a lot as well. So the death rate among Black individuals is 3 times as high as white individuals. But that's the data, right? And Ellen, you were talking about the people behind that data and how we need to be alerted to the issue and use the data in a way that lets us see, okay, we are aware that there's an issue here. What we need to do now is talk to folks, work with community organizations, figure out all of the perhaps trauma, social determinants of health, what is going on in an individual's life that might be causing them to need an external substance.
Exactly. When you have a conversation that's open like this, it gives the person an opportunity to realize that you are not just looking at them, but you're hearing them. We don't always listen. We say we're listening, but okay, what's the problem? They're writing as you're talking. I don't do that when I'm in the field. I want that person to know that I hear you and I see you as well. And going into a counselor's office doesn't always make you feel good. And when they're writing down everything that you're saying, you're not listening to me. You're writing what I'm saying. I want you to hear me. I want you to feel my pain. And that doesn't always happen. And that's an automatic turn off for me. Absolutely. But just the fact that there's a conversation about it makes me feel good. I wish that there had been more conversation with my grandson who died from a fentanyl overdose in 2014. We knew that substance was a problem. We just didn't know how bad it was, because they have a way of hiding these things from you. They don't look any different. They look just like you and I. But what they do when they're not with you is what is scary, and we could not save him. Not that we didn't try. We didn't have those conversations because we didn't want to believe it. And as parents and grandparents, we don't want to believe that our children have an addiction. It's not a pleasant thing to think about. But if I had paid a different kind of attention to him, I like to think he would have still been here. But the freedom to get this stuff, this fentanyl and all the things that are out there, and they know where to get it. Who knows that stuff? Would you think that you could call someone and they could come and deliver a drug to you? That's the world we live in, unfortunately. And it was easy for him to get it.
And again, that's why you made mention of, if you all were able to have a different kind of a conversation, maybe the outcome could have been different. And I know that we've talked a little bit about, the community and the impact of it, but a portion of our community is comprised of youth and young adults who are having conversations with one another So it's almost, in some instances, the blind leading the blind, because
Yes.
they're going by what they're hearing or what they've seen on social media or what's been glorified, by standards of, industries and things like that. Where when I was growing up, things like the DARE program, like that was a big deal. It made you afraid of, narcotics, but what it did not do was always give you language on how to have a conversation with a trusted adult.
Right.
Exactly.
Because you were afraid of, well, maybe they'll view me different, or maybe they'll judge me, or maybe they won't understand. Because even as a young adult, you mentioned about, sometimes they'll make a decision to ingest an opioid because it makes them feel better. But if there's no one to say, how are you? There's no platform for them to say how they really are. We're trying to eradicate the stigma related to mental health crisis in the African American community. Sometimes what is the word I'm looking for?
Sometimes that's the problem.
Yeah.
Is mental health. And as a people, we have ignored that.
Yeah, I think with substance use too, there is such a stigma there. And something else that the DARE program did was scare us all, but also make us think that everyone who used drugs was bad.
Yes.
And so I think that creates a really difficult situation with someone who is looking for help, but they don't want to turn to their parent or a teacher or someone because they might have internalized that and feel that they themselves are bad, where we know that humans are so much more dynamic and complex than being bad or good. I'm so sorry to hear about your grandson.
Thank
and
you.
I think that represents a really difficult time in opioids right now too, because fentanyl, not everybody knows when they're getting fentanyl. A lot of
Exactly.
times it's contaminating the supply. It's 50 to 100 times more potent than morphine. So somebody could be using their normal dose, and then if fentanyl is in it, they could have an opioid overdose. So how do we also have those conversations about, I understand that you're using drugs and I really, really care about you, and something that I want you to know is how to keep yourself safe. And so making sure that they have access to things like naloxone or test strips, or which is not, the place that we want to be at, but we do want them to stay alive. And so it's that conversation of, I care about you so much that I want you to stay alive, even if you are continuing to use drugs, and then we'll see tomorrow. Let's work on today, and then let's talk about tomorrow when we get there.
And sometimes it literally is a step at a time. For some people, they think that the step might mean I have to take 100 steps to equal the one. A step at a time could be the equivalent of literally a minute at a time. And having that support and having partnerships and having a village to help undergird and support you. So from a communal standpoint, I'm interested in kind of knowing from the both of you, how do you see strong partnerships forming between both, county and church? Because again, we just talked about partnerships being critical.
Exactly. My church has a program called Grace, and it is an amazing program that Pastor started talking about a few months ago, and it's being received very well, where the approach is not just providing the child with an alternative, learning how to do different things. In fact, I was surprised that this was going to get off the ground. But these children that are coming to him from detention are learning how to do other things. The Black church has always been instrumental in reaching our community. There's a church on almost every corner in my community. And that church is not filled with people that are well. We look at the church as a hospital. If you're sick, you go. And, okay, let's just say sinners go to church because we're sinners, because we are. But we have to be more open about accepting people. There was a time when I didn't want someone sitting next to me that smelled like weed. Now they can sit next to me, and I'm glad to have them, because maybe they'll get something from what is being said that will help them. As I look at the children that are involved with this Grace program, I'm seeing that they're learning through doing things that they didn't think they could do. They have opportunities that they didn't have before. They just went to juvenile detention before. Now they're coming to us, and we're teaching them how to have life skills, how to do things. But Pastor has gone a step further than that. He also reaches the parents as well. It's mental health, it's employment, it's all of those things that encompass that one little 15-year-old that's sitting in the pew with you. And dealing with the parents helps, because I've had the opportunity to stand in our Grand Rapids Public School entrances, and little kids like this get out of their mom's car or get off the bus, and you almost get a contact high. And you know that 6-year-old wasn't smoking weed. So do we need to be educating the parents as well?
Yeah.
Should it start there?
Yeah.
And we don't know what problems are in their basket either. We don't know what went on with their work, with their health care. There's so many layers to the human being that's almost impossible for an organization, try as you might, to get through all those layers.
Yeah.
But I appreciate the fact that you're trying.
Yeah.
Because we need it.
And then trying to do it alone is absolutely impossible, because you mentioned that there could be, Reverend Gaddy is being intentional about, connecting with the family and connecting with parents and finding out, because those social determinants of health are definitely, they are almost the great agitators, what I like to call it, because those simple things seemingly are literally the building blocks to how established or not a family and maybe even a generation could be. So as she's talked about the different ways that their particular ministry, along others in our community, because to your point, there is a church on just about every corner. And the beautiful thing about it, it's not relegated to a denomination.
No.
Any church is the hospital. So that's the beautiful thing about it. So how are you seeing that the county and church and community can have a more strengthened partnership?
It makes me so excited because the public health landscape, we work with the public, right? We're concerned about the public's health. We can do things like epidemiology, tell you the data. We can do things like prevention education, in K through 12 classrooms, and teach kids and figure out what grants are available and figure out what the evidence base is and what research is saying and provide that to community. But where those person-to-person interactions are happening are on the corners, in the churches, in our community organizations, with people like you, Ellen. And so I think that that's so magical, because it's like bringing public health infrastructure, data, research, alignment of all of our community resources, and saying, go and do. Like, we will support you, and we want to align, and we want to make sure we have similar messages. But your community, right? You know the folks who are coming into your pew every Sunday, and you're able to have those tough conversations, because there's a reason why people are going to perhaps one church or a certain coffee shop that they like to go to talk to their friends, or even a bar to go talk to their friends, or other types of community spaces to find community, to find that village, right? And so if we're able to work with all different types of organizations and support them, then we can kind of elevate public health from the ground up. Yeah.
And that needs to happen. I think the biggest impact is going to be in our church community. I get a lot of information just walking through the streets of my community. And my goal has always been to meet people where they are. So all those initials that I have behind my name, I don't use those, because that does not matter. That turns folks off. So how are you going to tell me what I need to do just because you are Dr. So-and-so, PhD? It doesn't matter when you're talking with someone who maybe slept on the street last night. What we have to bring to them is an understanding for what the problem is. And appearing to be greater than isn't always the way to go. So I have my blue jeans on and a sweatshirt. And let's talk. What can I do to help you?
That shared humanity. I love that.
It works. Yeah. It's worked for a long time. And I believe firmly that people would do better if they know better.
Yeah. And you mentioned about meeting people where they are. And, Rachel and I, we've had conversation through some of our opioid task force meetings about, again, meeting people where they are. And we've talked about some of the ways that we think that could be impactful. So I would love to hear a little more from you as far as the Kent County Health Department is finding, ways that they would love to meet people where they are, and we can, potentially even in this conversation, develop strategy even very quickly about how we can bridge that gap, because what we have not had prior to this moment, GRAAHI has had conversations with Ellen and others from different congregations. GRAAHI has had conversations with, Rachel and others from Kent County. But there hasn't been an Ellen and Rachel conversation,
Right.
for example. So I love that this is organically a brainstorming, we'll say. So like, what are some of the ways you would love for, your organization to be able to show up in community?
I feel like there are so many different ways, and there are so many ways that I am going to 5 minutes after we walk out of this podcast be like, I definitely should have said that. But the way that we kind of look at the opioid epidemic right now within the task force and within our overall county opioid strategy with settlement spending and everything is this continuum of prevention, intervention, treatment, recovery, and beyond. And so I think that within each of those realms, there is so much there that we could be coordinating on. With prevention, making sure that folks have access to the education and resources that they need, and partnering with churches and congregations on making sure folks know what is in the current drug supply out there, know that there are other educational opportunities available for their children, knowing basically like where they should go if they're trying to seek these types of resources. With intervention or harm reduction, access to naloxone, the drug that can reverse an opioid overdose, and making sure that, churches might be able to have that available. Treatment, like making sure that folks know where they can go if they are ready to seek treatment. Yeah.
People need to know what Narcan does. And it's a wonderful drug. It probably could have saved a lot of lives in the recent past.
Yeah.
Churches need to know that. A problem that I run into also is, okay, I have a problem with drugs. I need to get help. They go to get this help, and there are so many layers that they have to go through to get the help that they just say to heck with it. I was already depressed and sad. That's why I was doing drugs in the first place. Now I'm trying to seek help, and I got to go through all this to get it. Never mind. And I hear that way too often. It needs to be easier for our young people to access the care that they need, as opposed to being told we need to come back next week.
Absolutely. I definitely agree with you.
That just doesn't work. There's got to be a better way for people to get help when they need it. If they go to some of the agencies, I'm just going to make it real personal. My grandson was told he couldn't go to one agency because he had too much insurance, basically, so they sent him somewhere else. And then we had to make appointments to get him into that system. In the meantime, he was going on doing what he was doing. There's got to be fewer steps.
I agree with you. There's got to be fewer steps. There's got to be an easier door, and many different doors.
Yes.
Right?
Yes.
To access. There are a growing number of places that they're having same-day walk-ins. Because for a lot of times, if somebody is using drugs and they have a thought, maybe I want to think about a different option for my life today, that could be a super fleeting thought, and that can be gone tomorrow.
Exactly.
Yeah. And so I agree with you. We need to figure out better solutions for getting people into care, because it's so hard when you're making that decision, right? And you're basically saying to somebody, this is something that I'm wanting to change about myself. And that is so humbling. It can be the stigma there is
It's
huge.
a different level of vulnerability.
It is. It certainly is.
A different level. I'd be interested in knowing, because you just mentioned about there's a growing number of like same day opportunities. Was that impacted by COVID? The availability of that, do you think?
I think so. I think it was so difficult during COVID for this particular issue because our social structures were so broken. Folks weren't seeing each other. And we know that with a health outcome like drug use, that social support is so important, making sure that people are staying healthy, making sure that people know that they care. They have a community that cares about them. And there were some things that needed to change with our healthcare system, especially with things like people needing to go to the clinic every day to get their methadone or their buprenorphine. And so there were some policies that did change that made access easier. But it took a big event like COVID.
Yes.
And so if we could think about what are some other barriers that we're having with our systems and not have to have a big event like COVID, just really focusing on how do we get more people into care? What are policies like the insurance issue that you mentioned, Ellen, that if somebody says, hey, I want to seek some help today, that we can get them some help.
So in terms of the help that we're saying that we want to make a lot more accessible and readily available, we know that there's a lot of different initiatives and opportunities and conversations that are happening behind closed doors at a much greater level than ours, the powers that be will say. But I do know that one of the things that you mentioned was the Michigan opioid settlement. Yes. So I would love for us to kind of talk a little bit more about those, settlement initiatives and what those federal and local funds could look like, because some of that could be some of the catalysts for solving some of what your eloquently stated concerns are. So, and I also would dare to even interject that some of our viewers and listeners might not even know about this settlement and what that even means.
Right. Likely not. I am in such a little island in public health doing specifically opioids that is what I live and breathe every day. So I'll just explain a little bit about the opioid settlement. But it was because of the harms caused by the pharmaceutical manufacturers and distributors in pushing things like hydrocodone in the late 1990s, early 2000s, and the start of the opioid epidemic. There were a number of lawsuits that were had with companies like Mallinckrodt, Janssen, different companies. So Michigan and then specific jurisdictions within Michigan signed on to this opioid settlement. And because of that, Kent County is receiving $12 million over 18 years. So through 2038, we'll be receiving these payments. And that works out to about $600,000 a year for an issue that is reaching so many people. I think I read an article that 40% of Americans know someone who has died of a drug overdose. So that is 4 in 10 people know someone.
And if we can pause there for a second, the 4 in 10 persons does not mean 4 in 10 adults.
You are so right.
The 4 in 10 means 4 bodies out of 10. So it could be a young adult. It could be a youth. It could be someone in their, mid to upper 40s and 50s. So I wanted to kind of interject that because, again, we're talking about the science and humanity of it. It's important that people remember that this data equals a person.
Yes, thanks, Ashley. That's so important. Yeah. So the settlement in Kent County specifically, the Kent County administration is responsible for allocating those dollars. The administration has done a really good job of working with the Kent County Opioid Task Force and the Overdose Fatality Review to try to determine what are community priorities and does that align with our internal county priorities, and is there a way that we can meet each other in the middle. So we've been going back and forth for about, I would say, 18 months now, trying to figure out the first 2-year spend plan. And we are at a point where we're almost ready to go in front of the Board of Commissioners because there's a certain dollar amount that it exceeds. The way that the Kent County government works is the Board of Commissioners has to vote on the spend plan, which is another reason why local elections are just so important, because I don't think a lot of folks know their commissioners are voting on things like how we're going to spend opioid settlement money.
So we want to interject there one more time. What I heard you say was, Grand Rapidians, we need you to vote. We need you to know who your commissioners are. Vote like your life depends on it. So
Because
you heard that.
It
One
does.
of our staff members said, vote like your life depends on it, because, again, to the point of both yourself, Rachel and Ellen, it does. So I'm going to say it one more time in the camera. Vote like your life depends on it, because it does. So I'll let you continue.
Yeah. I have learned a lot within this process. Being an epidemiologist, I never thought that I would be interacting with our local government so much, but opioids are in the spotlight right now. They have been for a long time, but especially with this settlement money. So with the dollars, the spend plan that we have identified with community priorities and internal county priorities is definitely making sure we're addressing this disparity that we have seen between Black and white residents with the overdose death rate, because we know that that is something that has come out of the opioid epidemic, definitely after COVID. But then also addressing this continuum of care: prevention, intervention, treatment, and recovery. So within those buckets, we're trying to have investments that address each of the categories. So prevention, making sure that we have prevention education available through K through 12 students. Intervention, making sure that more residents in Kent County have access to naloxone, to fentanyl test strips. Treatment, we're trying to address making sure that people are able to access treatment. The initiative they're working on right now is more methadone and buprenorphine induction in the jail, because we know that a lot of folks in the jail have issues with substance use. And then with recovery, something that we have noticed is care coordination. And a way that we can get around that is having more peer recovery coaches. So more folks in our community who can walk alongside people who may or may not be ready for treatment, but maybe they have other needs, like they have issues with their housing or a job or childcare, or maybe they have missed a few appointments because of transportation. And we want to make sure that we're addressing those things that are maybe preventing somebody from living their healthiest life. But we know that the opioid epidemic has already changed so much from 1999 to now. And we know that it's going to change again through now to 2038. So that's why we're trying to do smaller 2-year chunks, at least to start, because we don't want to put all of our eggs in one basket. We don't want to invest too thoroughly in things that might not be relevant in 10 years.
That makes a lot of sense. So I would be curious to know, as you guys are putting together the plan for spending and things like that, how have you engaged the community to be a part of guiding what that need may be? Because I know, obviously we've had several conversations with the both of you about how important community is and meeting them where they are. But I would love for our listeners to hear, how they have an opportunity to engage in this space.
That is something that we have identified as needing to improve on in our next spend plan. So we worked really closely with our already identified partners with the task force and the overdose fatality review. They represent a really good swath of our county, but they represent organizations. They do not represent people. So we are hoping to have the initial 2-year spend plan. In the meantime, before the next spend plan, be doing way more engagement with community members around what they would like to see. Because when it comes down to it, this settlement is for them. The settlement is due to harms that the pharmaceutical companies have done to our community members, and they should have a say in how that money is spent. So we know that we can do better moving forward. We have, like I said, gone back and forth a lot on the spend plan and have made a lot of adjustments there. But those are people who are able to show up for a meeting between the hours of 8 and 5. So, we definitely can be doing better.
Yeah, that's a good thing to definitely know and hear, that there is an intent behind the work itself. And then also, I would say, broadening like how we cast that net to gather the information from the community, that we definitely have to not just serve and undergird, but also make sure that we elevate their voices. Ellen, as an active member in community and representation of community, I would love to hear your thoughts on what the potential of that spend plan is, and also the opportunity for improvement there.
I would love to see the Narcan in more places than it already is. I would love to be able to walk on the corner of Franklin and Eastern and look at that person laying down on the ground and catch them before they die of that overdose. The community would be receptive to that if there needs to be some education with it, of course.
Absolutely.
But there needs to be more of it. The places that have the biggest problems, and you see them, you try not to drive past those street corners, but that's where the program needs to be, because that's where the problem is. When you're walking down Division Street, all those folks that are homeless, can we touch them because we know how they're medicating. They don't want to have the psychotropic medications because that wipes them out. So they're either treating themselves with drugs or with alcohol. Let's go where they are. When we're handing out sandwiches and hot coffee to them through my sorority and church communities, can we hand them some Narcan along with some information? They know me. They don't know you. So will you come with me?
I love that idea.
That's how it will get this work done. The community wants this epidemic to stop. Folks like you and I in this room don't want people to continue to die, to continue to use. But help doesn't help if it doesn't help. Okay. So it looks like there's an organization that's willing to do it. People need to know more about you, though. I haven't talked about you at Pilgrim Rest, didn't talk about you at Messiah, New Hope. These are the places that you have to go. Because the grandmothers like me and the great-grandmothers like me are looking at their children, knowing what's going on, and they don't know how to help them. You might be that bridge. If they knew who to contact, where help was available at, we might get a few more people.
I definitely think so. And, to all of our listeners and our viewers, I think the beautiful part about this conversation here is that we know that the both of you, you have a personal investment in this, but you also represent a community of others that are, one band, one sound. So there can be a Rachel and an Ellen almost everywhere, right? So the showing up together, because it builds a different level of trust equity within the community, because in some areas and spaces where they trust Rachel, they don't know Ellen. So now they can build trust with her, and then vice versa. So I think that is definitely, it seems so simple because it really is that simple. Sometimes we try to make
we overthink.
There it is. We think so hard and so deep because sometimes the solution feels so big that we will omit the obvious solution. So we've talked about the different opportunities for information and access to, in the hopes of, developing a more strategic approach to it, a more collaborative approach to it. We've talked about the drugs, but for someone that's hearing this conversation that knows that there are life-saving measures out there and they're hearing you use these names for the first time, I would love if we could just kind of give maybe almost like a Cliff Notes version of like what the drug is and what it does. So if my 16-year-old will know what to do, my 61-year-old dad will understand it. And even unfortunately, my 6-year-old niece, she kind of needs to know that these things exist because social media is social media. So I would love if you could just very quickly just kind of give us if this is what this drug's name is and this is what it does.
So Narcan, I think I also at one point said naloxone. Naloxone is the generic name. Narcan is the brand name, which most people will find either over the counter at pharmacies now, which is new. There's also free Narcan in some vending machines. And there's a map on our website, accesskent.com/health, where you can find free Narcan. Okay, what is Narcan? It looks like those allergy sprays that you spray up your nose, but it reverses an opioid overdose. And it is not harmful if somebody is not experiencing an overdose. So how do you use it? Somebody, like Ellen, you mentioned, wanting to go to somebody who might be lying on a street corner, right? So if somebody is lying there, you can't awaken them. You shout their name, do a sternal rub. They're not waking up. You can use Narcan and spray it in their nose. And what it does is replace the opioids from those receptors and restores breathing, because that's what's happening in an overdose is respiratory depression.
So someone that's hearing this for the first time that just knows the word overdose, but they don't know what's happening, you're saying that it's suppressing
breathing.
Okay, so we need you to breathe.
We need you to breathe.
You need the spray to help you breathe again.
Yeah, and there's 2 doses in each box.
Okay.
So you can use the first dose, wait 3 to 4 minutes, and then use the second dose. There's a few other things to know, like putting them in a recovery position, which is to roll them onto their side so that they're not aspirating on any vomit. tilting their head back a little bit to open up their airway. There's a lot of training videos online about Narcan, and on the box there's some information as well. But yeah, so our website has those locations, and then hopefully with the opioid settlement, we'll be putting more boxes with free Narcan throughout the county, and I'm going to talk to Ellen about where we should put those boxes. Yeah, so that is a big one that folks should have. I just have it in my car, not when it's like extreme temperatures, I take it out, but it's just nice to like have to carry around in your purse or.
And there's an initiative, I believe, and Calvin reminded me, it's I Can Narcan.
Yes.
So that's something, just if people see that in community, they hear that in community, that simply is saying, with this, you can save a life. You have the capacity to do it. And it doesn't take a lot, even with trainings and things like that, we can, talk a little more offline about how to create those opportunities for training in communities. So you mentioned Narcan, and I always say this wrong,
naloxone. Yep.
Naloxone, thank you.
Naloxone, Narcan, same thing.
And then, so there's another drug that you mentioned.
I mentioned buprenorphine, I think. So there are medications for opioid use disorder, which is sometimes medication-assisted treatment, MAT or MOUD. And this is something that would be prescribed to an individual to replace the opioid. And sometimes folks say, well, I don't want to replace one drug with another drug. But the thing is, this drug is not going to kill you. And it is a maintenance drug. Some people are going to take it for their entire lives. That's totally fine. People take insulin for their entire lives. That's just another medication that some people might need to stay healthy. So there's methadone, and that requires a special clinic. And then buprenorphine, sometimes known as Suboxone. People can get that at healthcare systems. Some primary care providers prescribe buprenorphine. And it's a way for folks to make sure that they're not having those cravings or wanting to use substances that, as I mentioned before, might have fentanyl in them and might cause an overdose.
Exactly. And that is the information that I would be sharing with my church community, anyone that I feel is at risk. People don't know, and they do better if they know. And some of the things that are just common sense to you and I, some of these medications that you and I can go back and forth about, they just have no idea that is available. And I can see some little grandma or mother wanting to get their child to use that. An argument that I hear frequently, and you mentioned it also, is I don't want to use a substance to get rid of a substance. So nobody wants to use methadone, but it helps to get you where you need to be.
I think having trusted voices in the community to say this helps, it gives it a different weight in the room, because if I don't know you and I don't trust you, I'm not going to listen to you. But when I do know you and I've developed trust, then I am more willing to listen, consider, and even act, because it's that important. I know that this has been a very heavy conversation, a very heavy conversation, but a very necessary conversation. But I would definitely want to, as we kind of bring everything to a close, I would really love to hear from both of you, just, if there is a message to community that you would love to share, if it's a message of hope, encouragement, whatever that might look like. So I'll let you guys decide who wants to go first.
Okay, I will. My message to the community is very simple. Don't be afraid to have a conversation with your child, with your husband. It's not all children. There are many adult folks who need to hear this as well. It's not just a childhood thing. It's not a teenage thing. Children as young as 10, 11, 12 years old, because they've been exposed to it in their homes, just see it as a way of life, and they just slide into it. If you feel like you have someone who is abusing substance, don't be afraid to talk to them. Don't be afraid to repeat what you've heard today, because if just one person hears you, the goal is to reach one and teach one. So talk about it. That is the message that I have.
Okay.
Reach one and teach one. That is so good. I love that. I think my message would be to say that you're not alone. And I know that through data, because I see how many people are impacted by this issue. But I also know that from speaking with people like Ellen that there are many people out there that have this same issue or a history in their family with this issue. And there are folks out there who will understand what you're going through. Resources are available in our community and recovery is possible. And I think that substance use can be such a lonely issue for people to go through because of the things that we talked about before with stigma and internalizing, feeling like you are in some way a failure or not living the life that you want to live. And I think it's just really important for folks to know that they're not alone, whether they're the person who is going through this and using drugs or if they're a family member who has lost somebody. There is a lot of help out there.
We have had a lot of information shared here. I know we've talked a little bit about the Michigan opioid settlement. We talked about the Narcan vending machines and things like that. So we will be sure to make sure that access to information will be found on our website. We'll make sure that we'll try to tag it in the link of this particular podcast. So, families and loved ones and religious communities and neighbors will all be able to kind of access it and share it and, again, reach one, teach one. I want to thank the both of you for having this very candid conversation with us. We are hoping that all of our viewers and our listeners have found something in this conversation that they can take and plant as a seed of transformation in the lives of someone else. So again, thank you, Ellen. Thank you, Rachel. This has been Curated Conversations, a podcast presented to you by the Grand Rapids African American Health Institute. My name is Ashley Jones, and until next time, we say thank you.